This VAP is on mastitis. The objectives for this topic are to describe the anatomy of the breast, define mastitis, describe the epidemiology of mastitis, including incidence, causative pathogens, and risk factors, describe the diagnostic evaluation of mastitis, including physical signs and symptoms, laboratory evaluation, and relevant imaging, provide a differential diagnosis of mastitis, and discuss treatment options for mastitis. This slide shows the anatomy of the breast, which consists primarily of fat. However, most centrally, there are lobules, milk ducts, the areola, and nipple. Mastitis is the unilateral, localized, painful inflammation of the breast in breastfeeding women, often associated with generalized symptoms such as fever and malaise. It occurs in 2 to 10% of breastfeeding women. Women with breastfeeding difficulties, mastitis with a previous child, severe prolonged unilateral engorgement, poor milk drainage, nipple excoriation, or cracking are at higher risk for mastitis. In the early stages, presentation may be subtle with few clinical signs. The signs are unilateral and those of classic infection, including redness, swelling, induration, and tenderness. Patients may also have fever, myalgias, chills, or flu-like symptoms. In advanced infection, there may be a large area of swelling with skin changes such as erythema and/or axillary pain and swelling secondary to reactive lymphadenopathy. Very rarely, there may be septic shock. The most common cause of mastitis is Staph aureus. Methicillin-resistant Staph aureus, or MRSA, is seen in both simple mastitis and cases complicated by abscess. In a recent small study, MRSA was found to be the most common causative agent. Less common causes of mastitis include Strep pyogenes, E. coli, Bacteroides species, Corynebacterium species, and coagulase-negative Staphylococci. Mastitis is a clinical diagnosis, taking vitals and generalized symptoms into account. If the white blood cell count is increased with marked bandemia, it is suggestive of streptococci, especially group A. Otherwise, labs are generally not required. If easy to obtain, cultures of breast milk can be collected if infection is severe, hospital-acquired, or unresponsive to appropriate treatment. Blood cultures are not thought to be useful unless sepsis is suspected. Likely more useful if infection does not respond to supportive care or to the appropriate treatment is ultrasound imaging. It is the most useful modality for differentiating mastitis from a breast abscess and can also provide guidance for abscess drainage. Breast engorgement is distinguished from mastitis in that it is bilateral. Plugged ducts will lead to distension of mammary tissue due to milk stasis and present as a palpable tender lump. Galactoceles can be thought of as milk retention cysts, which may appear complex on ultrasound. They are soft and non-tender on exam and without any systemic symptoms. Excision is not necessary. Inflammatory breast cancer is the most important diagnosis to rule out. It is characterized by skin thickening, erythema, peau d'orange, and axillary lymphadenopathy. It is best evaluated by MRI. Primary treatment is to provide symptomatic relief via anti-inflammatories and cold compresses or ice packs to reduce local pain and edema. Contrary to some popular belief, an important aspect of treatment is to continue breastfeeding and/or pumping, as breast emptying is essential for resolution. In cases of extreme nipple excoriation and/or whole breast involvement with extreme pain or disability, ceasing breastfeeding can be considered. There is evidence from a small randomized trial showing that antibiotic treatment leads to faster clearance than breast emptying alone, though breast emptying alone can be curative. If refractive to all of the above, consider ultrasound with possible drainage as discussed previously. Empiric oral antibiotics in non-severe infection with low risk of MRSA include dicloxacillin or cephalexin. In non-severe infection with risk for MRSA, treatment includes TMP-SMX or clindamycin. In severe infection with hemodynamic instability or progressive erythema, vancomycin is recommended. The optimal length of therapy is not well defined, however. 10 to 14 days is thought to be appropriate in order to reduce the risk of relapse. If infection is persistent, more tailored antibiotic treatment can be established with breast milk culture and sensitivity data. In the cases of known breast abscess, incision and drainage is the most appropriate treatment. In summary, mastitis is a unilateral infection with an incidence of 2 to 10% in breastfeeding women. The diagnosis is clinical with generalized symptoms as well as induration, erythema, edema, and pain. Staphylococcus aureus, either methicillin sensitive or resistant, is the most common cause. The differential diagnosis includes breast abscess, severe breast engorgement, plugged ducts, galactocele, and inflammatory breast cancer. Treatment includes symptomatic relief, continuing breastfeeding, and antibiotics.